Okay, so I'm going to talk about the DME progression after cataract surgery. I think all of us, we know that progression of diabetic retinopathy after cataract surgery is a well-known phenomenon. And it is much more in case the surgery has been complicated. As well as the proposed mechanism we should understand and keep in mind is the breakdown of the blood retinal barrier and post-op inflammation. So these two things somehow we have to take care of. I think we knew it right from this ETDRS study in 1999 that if there is a mild NPDR, it may not really lead to worsening. It will do all right, like here it is shown. But in case of a severe or a moderate NPDR, it is going to worsen. So that is what is very important. I think this information we had right that time. And I just like to share one patient here, this lady. You can see the way why I've shown this patient is you can see there must be a lot of post-op inflammation in this eye. And you have well-placed lens. And she had, after 10 months, young lady, quite a progressive loss of vision. And when we look at it, this eye, right eye has a very mild NPDR. And look at the left, what has happened. That is what happened. It will come up like anything. You have even NVD and you have so much of edema here. Angiogram was done and you can see very minimal changes in the right eye, but left eye, you can see it is in front of you. So there are several studies which have shown association of ocular inflammation and progression of diabetic retinopathy. And the surgical experience leads to progression of diabetic retinopathy after cataract extraction. So I am going to harp on this again and again. You need a very good cataract surgeon for a diabetic patient, especially if there is a DME. And the long surgery is associated with, we know it, with increased post-op inflammation and increased breakdown of the blood retinal barrier. So definitely it will lead to worsening. So diabetic patient undergoing phaco appear to have doubling of diabetic retinopathy progression in 12 months after surgery, which is of course much less than intra and extracapsular, which we had seen in past. And I think you must all look at this study in 2017. This is the data from entire United Kingdom. It is their electronic medical records. It has exactly shown the same thing which we had shown way back in 90, which I projected 99. The risk of treatment requiring DME increased sharply months after, 3 to 6 months after cataract surgery for all grades of diabetic retinopathy. But patients with moderate and severe are at particularly high risk. I think that is what we have to remember. So that part should be always, I think we have to be very careful. If you have these kind of patients, if you have somebody whom you don't like, send for the cataract surgery to him. So the posterior polar cataract, uveitic, or a hard or a pseudo exfoliation. I'm just showing one example here. You can see there is a retinopathy. This is the right eye. Left eye, complicated surgery was done. There was a posterior capsular rupture, part of the this thing, nucleus went in. But you can see what has happened. The eye was lost. There was subsequently even a neovascular glaucoma. So you have to be very careful. It can go like a fire. So in cataract surgery and DME, achieve a good metabolic. Don't rush up with the surgery. And diabetic patients undergoing cataract surgery should have a topical steroid and NSAID treatment for longer time. Tell your surgeon. They should know it. They don't want to use these days. They feel pride. I stopped my drops. That is a problem. So they have trivialized the phaco. And intravitreal anti-VEGF or steroids can be used during surgery. They can be used before or after the surgery. And there are a lot of them these days using, I'll show you many studies where the steroids, especially Ozurdex, has been used during the surgery or a week before the surgery. And this definitely reduced macular edema, especially in DME. So at this time, as I said, there is a paradigm shift. In past, we used to defer surgery. Now we tend to do early surgery. And the early surgery is done because we have intravitreal anti-VEGFs and steroids. These have resulted, and we require also, because down the line, we can have better monitoring of these cases if we have removed the cataract in time. I'll show you this one case here, 60 years old female. You can see grade 3 intravitreal injections has been given, also triamcinolone has been given. This is Avast given. So many things have been done, and needs a cataract surgery. And you can see the Ozurdex was given right along with the cataract surgery. And you can see everything went back, improved. And this has been published from our group. This was a thesis of Anirudh Agarwal, I remember, in ophthalmology, along with Professor Gupta, Vishali, Dr. Jagatram doing all the surgery. They were giving, and you see, this became a benchmark. Even now, you look at this retina issue. They are giving injection during the surgery, and this is routine in DME patients, and that is what is important. So what are the recommendations? Achieve good metabolic control first. Don't jump for the surgery. Use topical steroids and NSAIDs for longer time post-op. It is very, very important. An excellent and quick phacosurgery is the way to go. I always put this, avoid multifocal IOLs in DME patients. I'm talking of DME. You may have a diabetic patient because they do very badly. Mostly people don't publish on this because probably there's a problem because many of the maculopathy patients, they'll do very badly with multifocal. Pre-op or per-op intravitreal Avastin, Lucentis, Eylea, triamcinolone, Ozurdex, anything can be used. But Ozurdex I have highlighted, if patient can afford, use it. If your surgeon is not confident, you give it 1 week before and get the surgery done next week. Once everything has been metabolically controlled, they'll do very well. Otherwise, if your surgeon, most of them are not confident, Professor Jagat is himself giving it on the table, Ozurdex. So he's confident, so that is fine. But otherwise, it can be given earlier. So in conclusion, always inform the patient of a likely decrease in visual acuity. Once you are doing a cataract surgery, especially if there is a moderate to severe NPDR, I have shown you the data. And of course, if there is a DME, definitely, then you are going to also take action, do something. More people are using steroids than anti-VEGFs, but you can use anti-VEGFs also. And treat DME before and after cataract surgery aggressively with all these things. That is what is required. You need an experienced cataract surgeon. I have mentioned that. It leads to more inflammation if it is prolonged. It's complicated. And post-op treatment should be more aggressive and prolonged. Inform your cataract friends. Though these are different cases, give it for a longer time. So thank you very much for your attention. I think we can discuss this here.